Thank you, Steve, for inviting me to speak about some recent developments in sampling. So we'll really go to another area of epidemiology, if you wish, or social epidemiology, or even social science. What we do in sampling usually, if the population is known and we have a sampling frame, of course we would like to do probability sampling because that will allow the best data for us to do multiple statistical procedures and comparisons, and we can generalize sample parameters to the population, etc., etc. But if we don't have a sampling frame and the population is not actually known or hidden or hard to reach, we may have to use other methods to enroll people in research. So, and this is, and there we go back to the main subject of this meeting, to HIV research. And we have talked a lot about statistics earlier. We heard a lot about statistics and causal inference and bias and confounding. All of these apply to the approaches that I will discuss with you today. So traditionally, sampling for hidden and hard to reach populations consists of non-probability methods such as convenience and snowball sampling. So convenience sampling recruits people from segments of the population that are accessible or available. Such where can we find people for HIV research? We find them in STI clinics, we find them in drop-in centers or other physical and more recently also virtual venues. During snowball sampling, we ask people to refer their peers with similar risk characteristics for evaluation and enrollment in our studies. But both these traditional methods, convenience sampling and snowball sampling, they are subject to selection bias, and we already heard about that, and results are difficult to generalize to the population. So during the past few decades, and I've been part of this in my own work, we have developed other methods, particularly venue daytime sampling, or time location sampling as it's called. Maybe time location sampling is a little bit better because in one of the countries that I worked, when we did venue daytime sampling, somebody commented, well, how can this be representative because it was all collected during daytime? So it can't be because these people are out only on the nighttime. So what have you been doing? So maybe time location sampling is a better term. Another method that has come to the front in more recent years is respondent-driven sampling or chain referral sampling. So what we do in VDTS, or sometimes we can do a hybrid with RDS, if some of the population is actually hidden and another part is not hidden, we can do hybrid, so that has been done. But in VDTS, so venue daytime sampling, we create a database of venues, and I'll show you a little bit about that. We load them on a map, preferably using global information system software. What we do, it's quite elaborate to do. It verifies and characterizes each venue in terms of type of services that are provided there, if services are provided. We look at safety, we look at accessibility, we look at opening times, distance from each other, owner and stakeholder support, foot traffic, that is the people that are attending, and the characteristics of the people who come there, and all at different times and different days in the week. What we do also in this method, and which is very important, is community consultation. So after that we go on with identifying venues. We enumerate the people that come there, how many that come there, how many are eligible and willing to participate in our work. And finally we select a venue set for assessment. And then we go out to consent, enroll, interview and test, or if that is applicable, educate people as well. So community includes collaboration with the government. I'll show you a slide about that, with non-government and community-based organizations. And that is all important to do before we get on to doing our research. And here is a photo. It's not a very recent one. I think it's in 2002. And the person in the middle there with the tie, that's myself. and I'm surrounded by my friends from the Bangkok police force that we involved in our research as well, because we were going out recruiting people at venues around town, and we wanted to avoid that some of my field workers were going to be arrested for whatever reason, hanging around at night late with, or giving out condoms and telling people how to avoid HIV, etc. So we had many of these different meetings with different people, and clearly this is a group of gatekeepers that you would want to involve in your work. I'll go a bit through this. So where can we find information about the venues? We can find it on the internet. Very often, you know, they list their maps as well, so we can actually find out where they are, and we can load them on the GIS map. So what we do is we physically would go to a venue and load it, you know, the coordinates, you know, load it on the Global Information System map, and you can see there the GPS signal is right here. It's called the Gay Positioning System signal, or also known as GADAR. You may have heard about it. And so here's the MSM venue, and then the signal would load the particular venue on the world map with a precision of about 5 to 10 meters. And here we have a map of Bangkok, and you can see here there are multiple different MSM venues in this case. One area is called Chatuchak. There is another area close to it, it's called Pradipat. Then we have other venues in downtown Bangkok, Ratanakosin, in the Silom area, Sukhumvit, and in Ramkhamhaeng. So this is those are many venues, and you will understand that when you go on to sample from these venues, that you have to take into account the distance between them, as you cannot go around town and, you know, with the traffic, etc., etc. So it's very important to load these venues on the map, so we can see actually where they are and what it takes to go out there to enroll people. So what we first do is enumerate. So basically we draw an artificial line, and when people cross the line, they're being counted on a little counter taken by the field workers to just have an impression how many people come there at a different time and a different day in the week. So we get a schedule looking more or less like this, a set of enumeration and data collection schedule. So we have parks, saunas, we have clubs, etc., where we go to enumerate, and later on also to go on to get to collect the data. So the enumeration, this is an example of what you get then, a table basically with the what we call VDT units. Those are hours, so we have different venues here, hours that we have been there, and the total number of perceived eligible men that were counted. And then we count actually a mean number of people per VDT unit, so we use that to calculate the number of people that we can enroll at a certain site. And then of course we can go on later to see how many men we have enrolled. So there's some pictures here of the actual data collection. At the you can see it's quite colorful, and it's actually quite interesting to do this type of work, because you really get to go out to the venues instead of doing it all from behind your desk. Here you have some pictures of the field work of VDTS. People complete questionnaires, and here it's on Palm Pilots. Now it would be on handhelds. At the time we took oral fluid, which we took to the laboratory to test, and people would be able to get their result later with a barcode. Obviously these things have changed now with rapid testing, etc., and finger stick, and so this really has been, there have been a lot of developments in this area. Now for respondent-driven sampling, we need to have a network, otherwise we cannot do referrals. So what we need to do in RDS is identify the number of seats, and we give them coupons to give out to their peers, And we look at the coupons to decide on the number of waves that have been completed as the sample goes forward. And I'll give you some examples of that. We may give an incentive for people that are younger or older, or people that are rare in the population, and we want to have them. We need to decide on the number of referrals that we want to have from a person. So we don't want to have one seat or one person referring too many people. So we set a standard for instance, like 3 per person. What we then do is to enroll these people usually at the storefront, where we also do HIV testing if that applies, and we go on with as the study goes forward, we create a graphic description of sequential and consecutive enrollment waves and referral patterns, and we evaluate these data for saturation as the sample goes forward. So what does it assume? RDS. Population members are connected and they have to know each other. They're also supposed to be able to identify and approach their peers, so they need to know who their peers are and where they can find them. And they need to be able to accurately report their network size, because that will be later on important to decide on the design effect that we're going to use in the analysis. Referral sampling, or RDS, assumes a Markov chain-based process in which the sample that is created is independent of the seed. So it's independent of where you start. The sample will have nothing to do with your initial seeds. Or in other words, the resulting sample is independent of the seeds that you have. And it produces a representative sample according to some characteristics of the underlying population. So here is a coupon from Cambodia, where you see, and this actually comes from the work from Lisa Johnson that she has done in several countries. There is a number on the coupon, which you use to track the number of waves and to see who is referring who. The name of the survey, people are required to give this to a friend, and the incentive that is being given, and here is then where people need to go, so it's back on the coupon. So there is a certain numbering system we can use to decide on the waves as the sample goes forward. According to the numbers, they are sequential. There's often money given in this approach, but we also can do other type of incentives, such as T-shirts or phone minutes or internet minutes, etc. So this picture shows an RDS sample referral patterns as it goes forward in different waves. So the seeds are here on the left, and these are the referrals. And as we go forward, here we have 13 different waves. Usually the RDS sampling starts or stops at wave 8 because the saturation has been reached. So if you sample more, it will not change the resulting sample. Here is some written work from Cambodia. Actually, it's a paper representation of a transgender network referral sample from 5 waves. So you can see here wave 1. Here's the seed. Here are the referrals, more referrals, and another wave. And here's wave 5. You can see you start with 1, but you have, in the end, you have several hundred. You may have several hundreds of referrals. This is a computer-generated referral graph, and the different colors are actually different networks from different seeds. And there are also 2 seeds that actually don't produce anybody and live in the top left corner. Here is what I talked about. So as time and waves go forward and the number of people increases in the sample, the composition of the sample doesn't change anymore. You can see that here from a study in Vietnam. So people having a boyfriend, as time goes forward, that percentage doesn't change anymore. Similarly with average age, and also here with the number having sex in public places. Here you see actually that the sample is still changing as people from different cities are continue to be distributed differently. Here it's Ho Chi Minh City and other sites. So what are problems in RDS? Networks may not be connected. Some population members may be hiding. Some may be hiding more than others. There is, up to now, there is no good agreement on the design effect. So the dependency of observations, because people refer each other, so the observations are not independent as we would require for statistical analysis. Also, RDS does not produce eligibility and enrollment rates, which you can do in VDTS. You can actually record the number of people that are eligible and see how many go forward to enrollment, how many refuse, etc., etc. You cannot do that in RDS. So when we compare the two, there is no sampling frame actually for either one. So we will always have problems in generalizing the results to the population of interest. Also because we do not have the population parameters to compare them with. So we still stuck with what we find in the sample, but we do not know how it looks in the overall population. I will continue with comparing this a little bit to see where, in what situations we may actually use each method. VDTS can be used when most persons at risk are not hidden. For instance, in this country, we have done a variety of VDTS samples at venues where MSM and transgender people congregate, because Thailand is an open society, so you can find people at venues. It may be different in, for instance, the Soviet Union or other countries around the world. We actually may prefer to do an RDS sample. Of course, VDTS is limited to the people we recruit at the venues, but actually those people may also be the ones that are in need of assessment and also in need of prevention the most. VDTS is not very difficult, but it's very labor intensive, because you have to go out, find the venues, see where they are, how many people come there, is there a gatekeeper and stakeholder support for entering them to collect data, etc. So, but even though they may not be representative for the population, still you can make comparisons over time. So it's good for comparing or tracking trends in risk behavior and HIV prevalence. So statistical methods for venue daytime sampling are well established. Cluster sampling of venue time clusters. An advantage is also that you really have to go out, so it really forces the researchers and public health workers to go out to venues and see what is going out there and interact sensitively with gatekeepers, etc., and people coming there. What I found in my experience is that VDTS is also easy to integrate in sentinel surveillance and has a high degree of being replicable. So RDS we prefer to do if the population is really hidden and hard to reach. It may represent the population of people that are connected or interconnected. So we may not be able to enroll, obviously, because it's a network sample, we may not be able to enroll people who are not part of the network. The assumptions of RDS are more complicated than VDTS because it assumes a Markov chain of events where the result is independent from the beginning, and that is very often, I think, it's a difficult statistical concept to explain to people, particularly if you are working with ministries who have to do surveillance and you have to explain these things. They may really not understand how this is possible and how it works. As the sample goes forward, the different waves, and becomes independent of the beginning, so it's more complicated. It may also be used actually for network-driven interventions, besides using it for research. There is also a large amount of software for RDS, and it's available on the internet. There are abilities to extend RDS for size estimation, so you can actually nest your size estimation or capture, recapture if you wish, or other size estimation methods, enumeration methods in your RDS. The downside is that RDS you can do from a storefront or from behind your desk. You don't have to go out, and I think you miss out on a lot of interesting and important experiences. It's more difficult to scale up, I think, because it's more complicated and you need really people from academia and researchers to implement it. And I think that is the end of my talk. Thank you very much.